Hi, this is Dr. Gundusky. Now we're going to talk about what hip and knee replacement recovery is like. So we're going to go over some of the aspects of recovery so you can really get an idea about what it'll be like after the surgery. Please look at my other videos about the surgery day itself and then also topics about hip and knee replacement. We're going to talk today about things like length of recovery, returning to work, driving after surgery, therapy, and pain management. So we'll cover a lot of different aspects of the recovery after joint replacement. So hopefully you find this useful. So recovery is such that it really starts as soon as you kind of get done with surgery before you leave the facility that you're in. We're going to work on therapy right away after the surgery, get you up and down walking, up and down some stairs before you go, and we'll teach you some simple things to do at home. And then most patients these days can go home on the day of the surgery. Most patients will get a local injection or a nerve block and can go home with little to no pain. And then let's talk a little bit about pain after surgery and what to expect. So this part we're really going to focus on the first kind of early recovery, the first 4 weeks after surgery. Okay, so total knee replacements, total hip replacements are big surgeries, and you will have some pain, but the pain should be very manageable, meaning you should be always able to walk, sleep, and perform therapy without severe pain. So there's a few things to know about hip and knee replacement and pain itself in general. Overall, knees are more painful than hips replacements. The knee is a more complex joint, it's more superficial, and it is a little more uncomfortable after surgery. The hip replacements are commonly not very uncomfortable after surgery. So that's one thing to know. Also, the knee pain generally gets more significant many hours after surgery and requires pain medicines for a few days to weeks. But it's really variable from patient to patient. Some patients require no pain medicines to very little, and some patients require more. But in general, the local anesthesia injection around the knee keeps most of my patients pain-free for hours after surgery. And then the goal is to tell you what to do with medicine so that you understand what to do to keep yourself comfortable after that and to minimize the amount of pain medicines you need. Hips usually have very little pain after getting home. A small percentage of patients have some pain really early after surgery, like in the first few hours, but generally that subsides within hours and doesn't return. And I'd say that's on the order of less than 10% of patients or so. And then after getting home, patients are comfortable to the point that most patients take little to no pain medicines after surgery. Sometimes the first few nights or first few days, but after a few days, most patients are not requiring strong pain medicines. We help control pain with what we call multimodal analgesia. So I don't want to belabor this too much, but if you think about why pain happens, you can look at the image down there and see kind of what I'm talking about. You know, your brain perceives pain. So every single pain you have in your body ultimately is transmitted up to your brain through nerves because there's some sort of trauma that's happened to the area outside of your brain, like wherever the pain is coming from, and that's being perceived as pain by your brain. And so the goal with what's called multimodal analgesia is to use multiple different and benign medicines to decrease pain and avoid side effects um, of more potent pain medicines like narcotics. So the general goal is to limit the amount of narcotic a patient needs after joint replacement. And we're really good at doing this because we tailor the medicines to you. We look at your medical history and the options available and really come up with a good array of medicines that will help limit the amount of narcotics you need and control your pain the best way possible. And so we use a combination of medicines very commonly that help control this. Again, if you look at the picture there, you see between the brain, there's nerves that go to the spinal cord and nerves from the spinal cord down to the tissues that are uncomfortable. So, for instance, in a knee replacement, the pain around the knee then is transmitted up to the spinal cord and the brain and perceived as pain. So, by acting at different levels, for instance, Tylenol, which affects the brain, and anti-inflammatories, which affect local inflammation, we can help decrease the pain overall and overall limit narcotics. So common medicines we will use to help control your pain include scheduled things like Tylenol, anti-inflammatories, sometimes anti-neuropathic agents, which help decrease nerve transmission, pain transmission. And overall, again, the goal is to limit opiates and sedating non-opiate medicines to as little as possible, because those are the things that can be addictive. Those are the things that cause side effects like constipation, itchiness, nausea, drowsiness, and that's really what we want to try to stay away from. They do play a role. We do need narcotics somewhat to control pain, but again, the goal is to limit them. So we're going to talk a little bit about the early therapy again, kind of the first 4 weeks. Just of note, this American Association of Hip and Knee Surgeons website does have some nice patient materials with videos for therapy before and after joint replacement if you're interested in those. And we will kind of go over some of the few aspects of therapy to think about. So early on, therapy is really important to ensure success. And really, for me, it's divided into two phases, which is early and late. So early, especially the first 4 weeks or so, we focus on safe mobilization. So for that reason, we start everybody with a stable device, which is a walker. Again, everybody starts with this because it's the most stable thing to walk on, not because we need to protect the weight bearing on the joint. These joints are very stable to the point that they allow for full weight bearing, but it's really the most stable thing to prevent falls, which we really don't want. And then we progress from a walker to a cane to nothing, which this occurs over days for hips generally and weeks for knees, about 1 to 4 or so. This process occurs, and that's what the therapist at home is going to work on with you. For hips, in the first 4 weeks, we're doing walking and gentle motion and what I would consider light PT, which is basically walking in and out of the house, getting around the neighborhood, but keeping walking to about a quarter mile or less a few times a day, maximum for the first 4 weeks. And that's really it for hips. Otherwise, they're transitioning from a walker to a cane, cane to nothing, and kind of doing that light exercises. Knees are different. Knees require more aggressive therapy. And for knees, it's motion, motion, motion. So whatever motion you have by about 6 weeks after a knee replacement is pretty close to what you'll probably have for the rest of your life. And so you need to get that motion early. And I always explain to patients, it's just like if you slam your knuckle with a hammer, if you leave it bent for 6 weeks in a cast, when you take that cast off, your finger is going to be incredibly stiff. So same thing with a knee, a hinge joint that moves back and forth. We're really going to work on aggressive motion with therapy to make sure you get good long-term motion. In both these surgeries, we also want to encourage frequent mobilization. So usually every hour for the first couple weeks when you're awake, getting up and walking, moving around, even for just short distances, because we want to prevent blood clots and we want to get your energy back and increase your metabolism and get your body back into health. And so that frequent mobilization really helps with all those things. Um, for both hips and knees, usually when the therapist says it's okay, but usually around the 2 week mark, we'll allow some short period, no to low resistance biking and elliptical. Um, and again, that American Association Hip and Knee Surgeons website is a nice resource for some therapy stuff. This is a bit of a laundry list, but it's good to know what things we're trying to prevent after a hip or knee replacement in terms of complications and problems. And you really play a big part in minimizing this risk. So in fact, patient factors are some of the strongest predictors of risk after surgery. Hip and knee replacements are two of the most common surgeries on the planet. And so we know a lot about them. We know what the risks are. We know what some of the risk factors for problems are. And patient factors are a big one. And also your ability to minimize those risk factors is important. So it's good for you to understand what they are and how to prevent them. So let's run through a few of these risks and ways we try to prevent them. So first off, blood clots in the legs, or blood clots that go from the legs to the lungs, which is called a pulmonary embolism. Those are some big things we try to prevent. Those happen very rarely, but they're not impossible. So things we do, things like medicines, most commonly aspirin or other anticoagulants, as well as doing ankle pumps when you're awake and using frequent ambulation. So those are the ways to keep blood moving in the leg. Blood clots happen from stagnation and surgery and clotting of blood, and therefore some activity will help decrease that risk. Lung problems also a little less common the way we do things now. Before, when joint replacement patients spent a long time on their backs in bed, either incapacitated or uncomfortable or hanging out in the hospital for a long time, there was more issues with lung issues. These days, getting up people quickly and walking helps prevent this, but also, especially for high-risk patients, we're going to use things like deep breathing exercises and that incentive spirometer machine you might have seen if you're in the hospital, as well as, again, frequent ambulation. Getting up and walking actually makes you breathe deep because you're standing upright and you're breathing in and out to get ambulating. So walking is another way to help prevent lung problems. Infection prevention, really, we do a lot of things before, during, and after surgery to prevent infection. There's really only so much you can do. That big thing is really just proper wound care per your surgeon. So whatever your surgeon says about keeping your dressing on for a certain time period, not picking at your incision, not submerging your incision, etc. Those are important aspects to help prevent infection from your standpoint. Nausea and vomiting after surgery, really limiting that. The key is avoiding narcotic medications. Those are the most common things that cause that. So as little narcotics as possible is the key to preventing that. And then when you do need to take narcotic medicines, taking food will help prevent that. Constipation can happen after surgery. I would say these days, again, with how little pain medicines most patients need with joint replacement, it's a much less of an issue than it was in the past. But some patients are more prone to it than others. Some people have baseline issues with constipation and they know their bodies. So we do give people some medicines to help prevent this. We also want to have a good diet high in fiber. We want to make sure you're drinking a lot of water and staying well hydrated. And also frequent mobility, getting up and walking frequently like we want you to do for other reasons is really going to keep your entire body, physiology, metabolism, and your intestines mobile and moving. So that'll help. Um, the um, the other aspect, the thing we want to avoid is falls. So early falls can risk obviously major problems, including opening up of the wound and things like that. So we want to prevent falls by staying safe and then prepare your house, staying away, making sure there's no hazards in the way, including like rugs and things that are trip hazards. So and going slow basically, like not going outside when it's not nice out, being careful if it's icy roads or for whatever reason if you have to go out and things like that. But just really being careful, especially in the early period after surgery to prevent falls is important. Later on, at about 4 to 6 weeks on after surgery, we're really in that second phase, which is more the strength and conditioning phase of therapy. Um, so what does this mean really? So for hips, after about 4 weeks, really you want to have about a few month period where you're slowly ramping up activity to full. So as an example, if you are a 50-year-old healthy active person who enjoys cycling and kiteboarding and hiking, um, most people really haven't been able to do that as aggressively as they want to because they have an arthritic hip or an arthritic knee. So from a hip standpoint, for the first 4 weeks after surgery, we're going to do what we talked about before. And then after the 4 weeks, we're going to take about a 2 month period to kind of ramp up so that you're going to get to where you are at 4 weeks after surgery to where you want to be long term, but kind of treat it like you're training for an event. You know, you're not going to go right from where you are at 4 weeks to hiking up a 10,000 or 10,000 foot mountain. You know, you want to take it slow and steady. So every week doing a little bit more in terms of time and endurance and resistance in order to kind of get you to where you want to be. So a slow, steady progress of increased activity, increased strengthening activities. So generally after the 4 week mark, everything is okay from an activity standpoint, but you just want to take it slow and ramp things up because a lot of muscles that haven't done much in a while and you just had surgery and you want to kind of take it slow ramping up. For knee replacements, we're going to focus on quadriceps and hamstring strengthening at this point to get good leg power and balance. And that really gives us better function and confidence on stairs and more active tasks. And that takes about 2 to 3 months to really bulk up. So if you think about it, the first 4 weeks after knee replacement, it's really mobilization and motion. And now you really have a leg that's still not really strong. So, and you really can't work on the strengthening much, and you really shouldn't work on the strengthening much in the first couple weeks because we really need to let those suture sites heal and not stress the tissues. And so we're really focusing on more on motion and mobility. But now it's time in this 2 to 3 month process to really focus on the power of the legs. So a lot of quadriceps and hamstring strengthening exercises, which therapy will teach you. So overall, if you think about it as a percent recovery, for a knee, you'll at 6 weeks you'll be about 33%, which I generally explain to patients is able to do most of the things you want to do, but not feeling great doing it yet. Meaning you can go on trips and you can do most of the things you kind of like to do every day, but again, you're not normal or great yet. And so I sort of explain this as doing pretty good at 6 weeks. And then at 3 months, most patients will describe themselves as being about 85% recovered. So this now should be very good or great. Not finished. There's still some recovery left. And really, if you look at results from joint replacement, there's changes at 1 year and 2 years out. But at 3 months, most patients should be doing pretty well. Hips recover faster, so most patients really feel pretty great at 4 to 6 weeks, and the entire process of recovery and therapy is easier and faster for a hip than a knee. Generally for therapy, hips are doing some therapy for 3 to 4 weeks, and then really just going to the gym with activities is tolerated after that. For knees, it's variable. So some patients will do therapy for at home for 2 to 3 weeks, and then some outpatient therapy. But in general, about 4 to 12 weeks total. Some patients are doing some form of physical therapy. Let's go over some frequently asked questions with recovery after hip or knee replacement. One common question and concern is that the patients have stairs at home. I actually have a lot of patients that live near the ocean and have houses up on stilts and tons of stairs to go up. It's just a normal day to day in their house. And stairs are okay. I mean, almost every single person that has a hip or knee replacement, if they're reasonably mobile and fit, will be able to get up and down stairs. We practice these before you leave the facility, and you will be able to get up and down stairs after surgery. You have to be careful. You have to use a railing, and you should watch your balance. But you should be able to get up and down stairs comfortably. For that reason, generally, most people do not need to move a bedroom downstairs. Most people will be able to get up a good set of stairs with a railing up and down to a bedroom once or twice a day, and should not be an issue. Showering usually is available and possible early on, so most patients can shower early after surgery, immediately for a hip replacement, a few days after for a knee replacement. We just don't want you soaking the incision in a tub, hot tub, pool, or ocean for a few weeks, and we'll talk about that. Working is variable, so most patients can get back to work within a few weeks. Work from home, like computer work, generally within days to weeks, most people can do comfortably. But again, we don't want you to be sedentary. We don't want you sitting around in front of a computer at a computer job for 12 hours a day and getting a blood clot. So we do want you to get up and be able to move. For office type work, generally like 3 to 6 weeks is sort of what I tell people. For more really aggressive jobs, more like 6 to 8 weeks. But that's sort of the general time frame. A lot of questions people have about things like sexual activity. Sexual activity is possible after joint replacement. Really, it's more a matter of comfort for instance, a knee replacement. You have an open incision and healing tissue, so you want to be reasonably comfortable. Hip replacement, positionally, you have to think about dangerous positions that could happen. But overall, most kind of standard day-to-day positions would be totally fine as long as you're comfortable from a soft tissue healing standpoint. Walking the dog is possible early, depending on your pain control level, but you also don't want the dog to wrap the leash around your legs and fall. So it depends on the size of the dog and that type of stuff. In general, if you have a big dog, you really want to wait 2 or 3 weeks before you've got responsibilities to walk a dog like that. Small dog, you might be able to do earlier, but you really just have to use your judgment and really judge the fall risk, because that's the issue that can really give you a problem. Golfing is a common question. Generally, I let people kind of start chipping and putting within about like 3 to 4 weeks. And then after that, kind of progressing towards more full swings at about the 6 to 8 week mark. Patients ask if they can run after a joint replacement. Generally, not a great idea. I have a lot of patients who run, especially on hip replacements, because they are durable. Smaller frame people I'm a little more comfortable with, but for the most part, most joint replacement surgeons, including myself, don't think it's a great idea, especially for young people, to run or jumping type sports on a joint replacement, just because of the theoretical risk of micro motion, which could potentially loosen components. That risk is relatively small, especially with hip replacement, but again, it's something that it's specific to you, but it's really dependent um, on your size and what type of surgery you have. Really, things to avoid are falls. So really, that within your control, out of all the bad things that can happen, there's very, very few things that are within your control. But one of those things is a fall, obviously, and you can't prevent all falls. But for the most part, you just want to be really, really careful of tubs and stairs and slippery surfaces and trip hazards to really prevent a fall, because that can really cause a problem early on. And then hip positions. About a little bit. The risk of dislocation with hips is very low, but the very extremes of hip motion that can put you at risk for dislocation, we talk about a little bit. In general, that's really high flexion of the knee way up, or extending the hip way backwards. And we'll talk more about those. But in general, especially with anterior approach hip replacement, that risk is low to the point that we don't talk about these a ton in patients that have standard risk. Some higher risk patients we will talk more about. So for more information, you should visit some websites, including my website, which has some different talks about other things. Also, really good information on the American Association of Hip and Knee Surgeons website and the American Association of Orthopedic Surgeons website. Those sites are there. and they have some good information about hip arthritis, knee arthritis, treatment options, and replacement. So remember, just trust objective websites for good sources. Try to avoid sites that are biased and sites that have a lot of anecdotal stories, especially sites that are trying to sell you something. Thank you very much. I hope this was useful, and I hope you learned a little bit about recovery after joint replacement. Thank you.